All right, welcome everyone to the November 2021 edition of the Pre-Hospital Care Research Forum Journal Club podcast. As a reminder, the Pre-Hospital Care Research Forum is dedicated to the promotion, education, and dissemination of pre-hospital research, and we believe it is the responsibility of emergency medical professionals worldwide to help build that body of evidence to examine pre-hospital emergency care. And so here on our PCRF Journal Club, we take a closer look at some of the latest research happening in EMS. And I am Remley Crow. Today, I am joined by Dr. Tony Fernandez and Jeff Rollman. And I'm excited to welcome some of the authors of our paper, Dr. Nicholas Harrison and Dr. Robert Dunne. As a reminder to our audience, the name of the article we're going to be looking at is Factors Associated with Voluntary Refusal of Emergency Medical System Transport for Emergency Care in Detroit during the early phase of the COVID-19 pandemic. And this is published in JAMA Network Open, which is really cool because that means all of you can read the paper for free. It's not behind a paywall, so do make sure to visit the link that's in your registration and download the whole paper. As always, this discussion is going to be paired with a Journal Watch article written by our very own Dr. Tony Fernandez. And so we encourage you to check it out at EMS World under the category of education and training. And I want to thank the audience, all of you for joining us today. Some of you are still coming on in. Before we begin, just want to remind you all that you can use the chat feature on your screen to type in any questions or comments as you go, and we're going to bring those into the conversation with us. So with that, thank you all. And since we have the authors here, I think it makes sense if we could go ahead and start off with some introductions. If you wouldn't mind just telling us a little bit about who you are, what you do, and how you got into EMS research. Dr. Dunne, I'll start with you.
My name is Rob Dunne. I am an emergency physician and EMS medical director in Detroit. I started doing EMS long before medical school. The first ambulance service I ever spent any time on was in Crystal Falls, Michigan in 1985. So a very different setting than Detroit in the Western UP. And I have, so I've always had some interest, and I didn't really know much about doing EMS research. And I had a great, like many of us, I had a great mentor when I was a resident, finishing residency, and started doing EMS research with Rob Zielinski, who some of you may know, and got involved as as kind of being the only EMS research person at my institution for many years. So I was the person who they would send any multi-center study to, and we were able to put together a good team of people and start recruiting EMS fellows, which we have a very active EMS fellowship. One of our fellows is the co-author on this article as well, Dr. Andrea Curtin. So, today we've got a great team, and we all kind of stand on the people that mentored us, and hopefully we're doing a good job mentoring them.
Definitely bringing more people over to the dark side of research. I love it. All right, and Dr. Harrison, would you mind introducing yourself?
Yeah, I'm Nick Harrison. I'm from Detroit, and I'm currently assistant professor of emergency medicine in Indiana University, but I was in Detroit doing my clinical research fellowship in emergency medicine. I'm a staff emergency, or was a staff emergency physician at that time, and getting my master's of science at that time. And I actually, my primary area of research was not anything related to EMS. I do heart failure stuff. I had a grant that I was working on during my fellowship that once COVID hit, just everything got shut down. And one thing led to another, talking to Rob and Erin Brennan, who was another person at Wayne State, who was one of our co-authors and really involved with EMS there. And we started talking about some things that we could do, and I started thinking about some things that we could do while I was kind of taking a hiatus from heart failure stuff. And that's how I got interested in this. And then full circle, the research director where I did residency, Bob Swore, who some of you guys might know, once we published this article, came back and was like, I knew I could get you to do EMS research.
Like many of us, the path to research is not always a direct one. but we're
And the
very
path
glad
to
that
EMS
you were
is
here.
even more convoluted.
You're not wrong. That's true. Well, I'm really excited to talk about this research, and I'm glad that it did happen. But let's talk a little bit about just even what the research question was before we dive into the fun parts here. So this was a study focused on factors associated with pre-hospital refusal of EMS transport during those early phases of the COVID-19 pandemic. And so I'm curious, how you all got involved with this question. What made you decide to take it on as a research study?
Yeah, so one of the things that was really interesting to me in the kind of earliest stages of the pandemic, there were a couple of papers and also just anecdote that came out showing or suggesting EMS runs are down, even outside of just EMS, emergency visits are down across the country. And at least one or two of those early studies, showed that there certainly was a lower rate of people arriving to the hospital. And there was some attribution in there that, yeah, we think that this is due to people avoiding care. But one of the other things that was going on at the time was there was also a much, much higher burden of people dying outside of the hospital, of people who end up in that silent denominator, who die before they come to the hospital. They don't get included in any kind of in-hospital study. And one of the interesting things to me was trying to think of a way that we could approach this, where we can more directly assess something that we could more closely attribute to voluntary behavior rather than the confounding of people dying pre-hospital and sort of quantifying between the two. And the other thing too is we wanted to we knew that like with this kind of study design for retrospective design, we're not going to answer all of these questions with any high degree of certainty, but we also wanted to know a little bit about who was it and why were these people ostensibly refusing care or not. So that's kind of how we came at it.
Yeah, and just to step back a little bit, we have one of the co-authors on here, Damon Gorelick, who is he's our token paramedic on here. He's the operations manager of what's called a medical control authority, which we won't get into the details of, but it's kind of a quasi-regional, non-governmental, unfunded mandate thing that we have in Michigan. But we're kind of responsible for the EMS data for a certain geography. And he is an incredibly enthusiastic user of the data, user of our state EMS information system, has set up lots of custom searches and things. So we ask a lot of clinical questions all the time, and we've done it for years with our EMS data. And he's been a real key to that. And during the beginning of the pandemic, we really were looking closely at what kind of things were changing. There's kind of a companion paper to this specifically looking at cardiac arrests and out of hospital deaths directly, and that kind of led to this, because we had a lot more refusals. We actually piloted some telemedicine during this period of time under a state program, but we were really seeing that change that Nick was talking about in terms of volumes, numbers, and we've got decades of data, so we know that other illnesses are didn't go away, didn't stop, and wanted to kind of try and get a little bit better handle on that. And the other thing that we've done some work on across our state was looking at a lot of the disparities to begin with. We looked at disparities in cardiac arrest care a couple of years ago on a paper that one of our research fellows had done, one of our regional research fellows. And it's back to the old argument, your survival shouldn't be determined by your zip code or your geography. And and we, like everywhere else, we're still seeing that.
Yeah. Oh, absolutely. I love how you all use the EMS data to put some evidence behind. I remember at the time, seeing in the local newspaper, on TV, oh, well, where have all the heart attacks gone? It seems that people are not going to the emergency department anymore. Where have all the strokes gone? because we wouldn't expect that those things should change during a pandemic. And so I think that this is a really important way of answering that question. Well, do we see the same thing pre-hospitally? And another point that you made that I want to take a moment to highlight is that you had a paramedic on this paper. So I'm wondering if you have any advice to street EMS clinicians who might be interested in, seeing if research is something that they are interested in. What would you recommend to a pre-hospital provider if they wanted to get involved in this world?
I think Rob can probably answer a good amount of that question, but I can say that one of the things for me, coming from not necessarily from an EMS research background before me and Rob started working together, one of the things that I got a great appreciation for is just how much untapped potential there is to, Rob hit it right on the head. Like we wouldn't have approached it this way if we didn't have a data set that worked. We would have kind of just said, oh, well, it'd be a nice question to ask, but we don't have the data to do that. And I think what, I kind of knew maybe intellectually, but didn't fully appreciate till we got done with this was just how unique EMS data in particular is in terms of capturing what often just goes uncaptured. Going back to that idea of, sort of quote unquote silent deaths, those don't get picked up in most large clinical trials or, other hospital studies that are, not checking for people who die outside of the hospital or people who are treated outside of the hospital. And I think there's a lot that can be done on this side of things. So Rob can probably talk more about, how to get involved, but as for the why to get involved, I think there's a lot that can be done in EMS research that, I didn't have an appreciation for until I started working with these guys. So.
I think the key thing is don't be intimidated. I remember even as a resident and a student kind of being intimidated by faculty that were doing research and going out and publishing stuff that, they were somehow like up here and you needed like special dispensation to go talk to them or something like that. And I know I've heard that sometimes from paramedics who we've worked with and paramedic students who we kind of brought into the fold as research associates, is that they didn't know like how to even approach it. So number one, do not be intimidated. Go ask someone. Like most of us, I can only speak for kind of the people that I hang out with in the EMS research community, but a lot of them too, Remley. Most of us would be so excited to have a paramedic reaching out saying, hey, I'm interested in doing a project. And we would do a lot to mentor, find a project, and and we try to go out and say and present like, hey, these are some projects we have going on. If you've got some ideas, come on in, but just don't be intimidated. Go ask. You can't win if you don't enter. And there is, and I think that the EMS research community is the most approachable, down-to-earth folks. Many who were former pre-hospital providers or even still current pre-hospital providers. So don't be intimidated. Go up and talk to them. Look at articles you see. Reach out. People's emails are on a lot of their articles, and just reach out. Seriously.
Yeah, no, that is the perfect advice for this. I know that a lot of times there's this perception of you have to do it all and you have to know it all, and that's definitely never the case. Everybody, I have to know statistics. Well, not necessarily. You should have a methodologist and a statistician working with you, but you no reason to need to know every single piece of this. And I've never published a paper where it's only been my name on it, so it's definitely a large team thing for sure.
That's right.
Yeah.
But I love that you included a paramedic because I think it is important to have somebody who lives in the setting where the study takes place. And we talk about study setting on this podcast so often. We often mention the randomized control trial of the parachutes, where if you do it when the plane's on the ground, it's really not the right setting for testing the question you're trying to answer. So I think I would like to talk to you all a little bit about the setting where this study took place for those who aren't as familiar with Detroit CMS system. And probably Nick has heard this phrase already. If you've seen one EMS system, you've seen one EMS system. And so while we get talking about study setting, we'll also bring Tony back on to help us through the rest of the methods. But let's go ahead and kick off with just where did this take place?
Yeah, so DEMCA, or the Detroit East Medical Control Authority, which Rob alluded to, is several different EMS agencies that cover the city of Detroit, which is geographically massive. For those of you who don't know, for a city that has a population of 600 to 700,000, the city of Detroit is just enormous geographically, because half a century ago it was 1.5 million people. So
144 square miles.
Yeah. So it's a very large geographic area. Within Detroit, there is Hamtramck and Highland Park, which are two municipalities that are kind of geographic islands within Detroit, and then
right, completely surrounded by city.
That's right. And then sandwiched in between the Detroit River and Detroit, Detroit on the west and the Detroit River on the east, there's a very affluent suburban area that is also covered there, called Grosse Pointe, which is included in the data that we had, and the area that's covered by the control authority as well. As for some things to know about the population that we have in Detroit, actually, Remley, if you don't mind going to figure, it should be figure 1, I think. Yeah, so you have a very, this is, and we're going to talk about this more later, I think, but one of the things that is out there that's just a wonderful tool. There's this social vulnerability index that is geocoded to census tracts and captures a whole bunch of different forms of social vulnerability. From a 10,000 foot view, the city of Detroit proper is very, very high in percentile wise in a lot of the individual social vulnerability categories and overall. So you have a very vulnerable population in a lot of areas, but then you also have these kind of little clusters, like I was talking about Grosse Pointe over on what's going to be the right of the figure, which is all sort of purplish, which is super affluent and is just right there next to some areas that have much higher social vulnerability, not just from financial status, but from all kinds of different factors as well. So
yeah, I think this. Go ahead.
I was going to say I was just going to talk about EMS system characteristics. In general, what we have is primary fire-based EMS with highest priority calls getting a fire engine or squad plus the nearest available ambulance, regardless of whether it's a BLS or ALS ambulance, which is somewhat unique around the US. We just don't have a lot of ALS resources. And then that's backed up by private EMS agencies during peak times of day. Some of the smaller communities that Nick mentioned, although they're all kind of dispatched by the same 911 center, have more of a public-private partnership where all their all their primary 911 calls are taken by a vendor-based private ambulance service providing 911. Many of them that are partially owned by some of the health systems.
And can you tell us a little bit about where this data set comes from?
Yeah, so as Rob was saying, DEMCA maintains a record of every run that's made. Actually, I have to, the editor at JAMA wanted me to change, I had to change the word run throughout the paper to response. They thought run was too much jargon. But
if that's the worst reviewer comment you got, you're in good shape.
Yeah. I was happy about it. Yeah, I mean, I'm not complaining. Every run or response or whatever you want to call it is recorded.
We call it run on this podcast. Everybody knows what we're talking about.
In Nemesis world, it's event.
Yeah.
Event. Yeah. And so from there, we have the address at which the scene response was from, the home address of the person. We have a sort of brief descriptor of what the call was for into one of several different categories, and then stuff about the disposition of each person from scene arrival. So whether that was CPR on the scene, taken to the hospital, CPR on the scene, pronounced dead, pronounced dead on arrival, arrived, patient is okay, but they've refused transport, and everything in between, that's all in there. And so that's where we started, was we had 80,000 different responses that we then geocoded and cross-matched with this publicly available data set that the CDC has for the Social Vulnerability Index and some other publicly available geographic data as well to census tracts.
Not a small data set by any means.
No, definitely one that I had to save and cross my fingers several times on my laptop to make sure I was professional.
We've all been there. Now,
one of those things that Nick did that really, was a ton of work, but really is to take those things and put them together. That was really what was unique. We'd done some more superficial type projects like this with some cardiac arrest data by census tract in the past, but this was a very kind of sophisticated connection of a lot of factors that these data sets are out there, but they hadn't really been connected in this way.
right, and that's such an important point, being able to link these disparate data sources to tell the full story, and this paper does a really great job at that. I'm going to let Tony dive a little bit into the actual methods behind this paper, so go ahead and ask away, Tony.
Absolutely, and I just want to thank the authors again for joining us today. I think this is a really well done paper, and I'm excited to talk about it. So let's jump in, and your stated objective was to examine the factors associated with EMS refusal in relation to COVID-19 cases, public health interventions, EMS response, and pre-hospital deaths. So as we've all heard multiple times from Dr. Crow, when you're comparing things, you comparing apples to apples is oftentimes not good enough. You want to compare the Granny Smith to Granny Smith. So can you walk us through your definitions for patient refusal, your definitions for what constitutes a pre-hospital death, and then how that relates to how you counted your EMS transports?
Yeah, absolutely. So this, again, it goes back to the idea that we needed, from the moment that we had the clinical question in mind, we had to make sure we had the data set to be able to do this. And luckily, in the DEMCA data set, that's one thing that's very granular. It's recorded on every run. Not to get like too technical as far as like data management stuff, but it was really important to me that it was something that the provider had to select from a choice of specific options. It wasn't just like free texted in, because when that happens, you get some stuff where you get missing data or you get data that's hard to interpret or ambiguous. And one of the first things I did was sit down with Erin Brennan, one of our co-authors, and we went through and saw that, yeah, we have all of this at a really granular level. So refusals were fairly straightforward in the sense that anyone who was alive at scene where transport was indicated by the disposition variable in the data set, and which they refused against medical advice. That was our definition for a refusal. Anyone who died prior to the hospital, so that included anyone who was coded in the data set as being pronounced dead on scene or being pronounced dead after resuscitation, but prior to arriving to the emergency department. So patients with ROSC or patients with CPR in progress were considered transported. And so then from there, we have all of the EMS, the 80,000 EMS runs, and that's your big denominator. But part of what you want to know, to ask this question that we were getting at, and is really we want to know a slightly different denominator, which is of the runs where someone could refuse. So if someone not to be too morbid, but if it's a patient who's passed away, who's died, obviously they can't refuse. And that might sound a little weird to harp on that point, but that was actually something that we felt hadn't really been answered before in what we had in some of the prior literature. And so we wanted to make this distinction of just transports, so people who were alive, able to be transported to the hospital, and had the ability to refuse, but didn't. So that's kind of where we came to those different definitions.
And I think that this is really important, and it goes along with a question that just popped in from an audience member. Chris is talking about, in the past data, we've seen trends and differences in the non-transport rates of 25% and differences by provider types. And one thing that I want to chime in on here is that it really depends how you classify those dispositions that Nick mentioned. So a lot of times the call canceled dispositions can make that difference too. Do you count a call canceled or no patient found or no patient contact as a refusal, or do you throw them out? So a lot of that can actually affect these not apples to apples and definitely not Granny Smith to Granny Smith apples comparisons. So I appreciate that you took the time to define so clearly in the paper as well, what was in the numerator, what went in the denominator.
Yeah, thanks, Emily. That's exactly what we were trying to nail down as we were kind of reviewing the prior studies that had been put out there. And yeah, it makes a big difference because just a few different people on either side does change the results quite a lot.
Absolutely. Absolutely. So as we move through your paper and when we start to talk about your results, we got a little bit of a preview of this earlier. You used the CDC social determinants of health, and you've given us a brief kind of intro to that. But I think in order to really put your results into context, can you walk us through the social determinants of health? What are they? What do they mean? And what I think will really be important is to talk about how they're evaluated.
Yeah, so the Social Vulnerability Index, like you said, is from the CDC. It's coded to census tracts in a very large data set, and there's a composite Social Vulnerability Index that's on a 0 to 15 scale. There's 4 subcategory scales, and then within each of those subcategories, there's individual components. So actually, if you go to, I believe it's table 1, we kind of lay out each of those factors that are in there. Let me see if I can pull that up really quick. Yeah. So kind of going in reverse order, starting at the very bottom of the table, we have the overall SVI 0 to 15. And then you have these 4 subcomponents, what is referred to in the SVI data set as a theme. Not all of which are the same, by the way. So like race, ethnicity, language is 0 to 2, but socioeconomic status is 0 to 4. So that's how it was designed. That's how the CDC made the scale. But just keep that in mind that not all components are weighted equally as far as the overall SVI. Or not all themes are weighted equally. All the individual components, which is everything from no health insurance at the bottom to below federal poverty line up at the top. Actually, I'm sorry, the health insurance is the only one that's not actually part of the SVI, but it's part of the same data set, so we include it in there. Group living quarters up to below federal poverty line. Those are the components that are in the SVI that are individual. And here, these numbers that you're seeing are the percentiles compared to the US at large.
And what a great resource, and I think you used it really well in your paper. And I think I'd really love to see more of this, pulling in public health into EMS research. And there were some words that, again, we have some budding researchers as in our audience, and not everyone may know what a census tract is. So for those who don't, I actually have up here the CDC's definition of census tract. So that's the census definition of their own census tract. So they're small, relatively permanent statistical subdivisions of a county, and they are all uniquely numbered. So think about within a county, sometimes it could be a few blocks, sometimes, but typically they're around a minimum population of around 1,200, and they typically don't go over about 8,000. So that's what we're talking about when we're saying that these are distributed by census tracts. And so, just for a little background, what you were able to use these census tracts, and you were able to geocode using another free data set, the U.S. Census Bureau's Tigerline public data set. And we likely have few steps for a lot of our researchers before they become proficient geocoders, but can you walk us a little bit through that process so they kind of understand how you did all of what you did?
Actually, before we get into that, I think that's an important thing, but I think I just want to emphasize this concept of census tracts, because we have used it, and shout out to Alex Hill, who's a public health geographer, who's one of our co-authors. We've been using that for a number of years to look at our EMS responses as it relates to different disease processes, cardiac arrest in particular, where we looked at risk of cardiac arrest by census tract, as well as the chance of having bystander CPR. And then we use that to target actually CPR training even on a door-to-door basis in areas. It is an incredibly powerful tool, and it ends up being not that complex to use if you can, find a friendly geographer to work with. We used it for looking at asthma, particularly childhood asthma, and led us to develop a protocol for treating asthma a little bit differently in EMS. And it is just a really, really good tool for a lot of things, not just research, but understanding your community. And then particularly the SVI side of things is that, we know that having more social vulnerability actually goes along with increased use of both EMS and emergency services at the hospital in general, poor access to care, and some significant health outcome differences that I think a lot of us, as we've been getting into more mobile integrated health and things like that, are aware of. But these are great tools. They're not obscure tools, and they're out there as data sets. And Nick was just instrumental in kind of helping us put them together.
Yeah, and I think thanks, Robin. Tony, to your question about sort of the overall view of what we did to piece these data sets together. I think I can't remember who it was, but it might have been my dad or a family member made some joke a couple weeks ago about like, oh, so-and-so is gonna get a geography degree, and they meant it as a pejorative. And I immediately was like, no, that's actually one of the coolest jobs you can have in 2021. And it gets to this idea that all of these data sets there's lots of this publicly available data that codes things like the boundaries of a census tract first, to specific spatial coordinates, to actually multiple different coordinate systems that you can some you can interchange with one another, some you can't, and that you can actually locate and create a digital map of data in space of where the boundary of one census tract begins, where another one begins, and from there you can code specific things like what we did with having the scene address, and say, okay, well, this EMS run happened at this scene address. If we pair it with the data set that tells us where the census tracts are in digital world, we can then find, okay, which census tract was this one in? So where did each run occur in each of these 334 different census tracts? And that's how we pieced all of this together, using the primary EMS data and then the publicly available data, which there's a lot you can do with it that has some really profound public health implications beyond what I've done here or what we've done here. I'm not a geographer professionally. Our co-author Alex Hill helped me a lot with learning that side of things. And there's just an endless amount of really cool stuff that you can do for public health purposes using this kind of technique.
Absolutely, and yeah, geographers are not a pejorative. It's not a dirty word. I hope that folks out there who are listening do go into these types of studies, because there's just a wealth of things that we can do that are untapped at this point. So just moving right along, it probably does seem intuitive to most folks on the call why you wanted to compare the same time period between 2019 and 2020, but again, a lot of folks are just starting out. So can you give us just a brief explanation of why you thought this was important? Why couldn't we just look at 2020 numbers? Why did we need to compare to 2019?
Yeah, great question. I think if you don't mind going to the E figure 2, I think it might help to look at it in terms of this really E2 through E3, E4. Oh, the supplemental figure, sorry. Yeah, so one of the things that, because we were trying to not just understand what was going on overall during this time period, but also what was going on through this time period. One of the first things you have to account for is seasonal trends. So is there something where for some reason in a quote unquote normal year, where in this case we chose 2019 as our ostensibly normal year, you know, do a whole bunch of people call EMS and go to the hospital in the middle of May for some reason? And you know, that could be any number of different things, but if there is something that seasonally is there, you need to be able to account for it so that when you're looking at what's going on in the period of interest, in this case, you know, kind of second quarter of 2020, you want to be able to see, okay, well, if there was a peak there in 2019 and there's a peak there in 2020, are those peaks overlapping? Because if they are, then that's probably just the quote unquote normal, some kind of normal trend rather than something unique to 2020. So that's why we had to have a comparison there. It does bring up the question. I mean, one of the limitations of the study is we can't guarantee that 2019 is the same as 2018, although we did some various things to try and reassure ourselves of that. One of the things that we noticed is that we did a time series analysis, which I won't go too into the details of, but looking at 2019, which is in red at the top of that E figure 2, there's no real trend across this 3-month period, neither by visualization or just or by some of the statistical methods we used. During that 3-month period, there doesn't really appear to be any spikes, any elevation, any declines in the number of runs per day, the number of deaths per day, the number of refusals per day. So we felt that probably made a pretty good baseline. But that said, one of the limitations is that we can't guarantee that that's not different than 2018 or 2017. But
yeah, where do you plot your normal stick, right? Yeah, I get it. But so that's absolutely a moving target. But I think you all did a wonderful job here. One other definition I want to get through. I always have the unenviable task of holding folks up to get into the really exciting results. But one other definition we do have to get in here is you used your median for your cutoff for high refusal versus low refusal census tracts. I think that'll be important as we move through. And you adjusted for age, sex, your total SVI score, and the date. Was there I want to get across to some of our folks that things don't always work out exactly as you want as you're moving through these analyses. So can you talk to us about, you adjusted for some very important variables, but were there other variables that you would have liked to include that you couldn't for one reason or another?
Oh yeah, absolutely. So I mean, first, it would have been nice to have been able to adjust for the specific component variables in the SVI rather than using the whole SVI score. But you get into, I won't get into it too much, but you get into statistical problems, if I said to say, where you have too many variables that are related to one another and change related to one another, and it just causes a mess in the models. I think, you know, there's certainly other variables we would have liked to have included. Having patient level data would have been helpful as well. So knowing not just where, you know, we had age and we had gender, but having comorbidities in particular would have been a really helpful one, I think, to know, you know, okay, is this person or are the encounters in this tract more related to people who have hypertension, have heart disease, who are sicker at baseline, and is that somehow affecting the results? That's something that would have been really helpful. I think probably the #1 thing I would have liked to have had, but we just didn't have that in the data set.
Yep, and I mean, the point there is just to not let the perfect be the enemy of the really, really good. And your paper is really, really good. So before we start talking about the results, I just want to open it up to our other panelists to see if there are any other methods-related questions that I missed or that you wanted to talk about before we actually talk about your results.
Yeah, so we actually have a couple of audience questions from both Jake and Chris kind of hitting at the same idea. So I'm going to synthesize them into one here. And that's going back to that definition of refusal by patients and this voluntary refusal concept. We know that based on the NEMSIS, which is the National EMS Data Standard, everybody has the same options to choose from in their EHR. And so no treatment transport required. Maybe we should talk about how you deal with that. And are there limitations to using what was documented by the paramedic and any potential for implicit bias in how things got coded?
Yeah, so I think the second part is especially important, and that's the trickier one. To be perfectly honest, we can't measure for implicit bias and how that may have been coded. We can only trust that people were coding it to the best of their ability and in a fair way. But to your point, my own opinion is I think it's fair to assume that there probably is some bias in there in terms of how people code things. To the first question, we did try and separate.
Let me just expand on that too. And that's something we definitely had a concern about when you're talking about comparing historical to the pandemic, is that, you know, that some of the way that's documented and some of that bias may have been changed. Particularly, you know, we were hit very hard very early on in Detroit, you know, before a lot was known, lots of fear, lots of, you know, significantly overwhelmed hospitals, fairly high in-hospital death rates, particularly at some hospitals. So exactly what that discussion is, you know, what is the content of that discussion that somebody might be having in a house or at a scene is definitely could lead to a bias that's different than a historical bias that may already be in there.
Yeah, I think to that point, one of the data points that really stood out to me, if you look in that table 1 again, and you go through the different individual components of the social vulnerability index, one of the interesting ones that really stood out to me, you know, there's pretty large differences between the high refusal tracks and the low refusal tracks. And most of them, unfortunately, fall along what, you know, we would expect as far as, you know, vulnerable groups having, you know, having higher refusals. And we'll get into more of, you know, why we, you know, think that may or may not be later. But one of the ones that really stood out as a kind of outlier was that limited English proficiency was actually a really strong predictor of being low refusal. And that, I think, again, we can only speculate based on this, but one of the questions here is, okay, well, is that because you have providers who are basically just scooping people up and taking them, and you can't have those informed decision-making conversations of bringing people in, but we don't really know.
And I think that goes to highlight the point of these large retrospective studies are really useful, and oftentimes they raise more hypotheses or they generate questions which can then be looked at using a different approach, a prospective approach perhaps.
Yeah, exactly.
So this is excellent.
That's the point here is, this is a hypothesis generating study. It tells us a lot about, public health in general and the question that we're asking, but to really nail down these questions with a higher degree of certainty, you need a prospective study where people are out there on the rigs, collecting data in real time.
Absolutely.
Which obviously we couldn't do during March 2020.
And before I turn it to Jeff, this also highlights the importance of the EMS clinician documentation. So I remember, as an EMT, I might think nobody's watching and why am I going to waste my time scrolling through all of those primary impressions to find the perfect one? But the accuracy of the documentation really has a profound impact on our ability to answer some of these important research questions. So anytime I can vouch for good documentation, I have to do it. And so Jeff Rollman, I think you have a question.
Yes, yeah. First of all, thank you so much. Definitely a huge honor to be on with you and to have you all here. Yeah, thank you, Dr. Dunne. Thank you, Dr. Harrison, for sharing your terrific work. In terms of data, I was also thinking about another data element. We were just talking a few minutes ago about additional data that you kind of wish you had and could have thrown in the model. We talked about time. You did those really great time series analyses. I was also thinking about time, not necessarily the days and months and those year-to-year comparison, but the smaller increments like minutes, like times on scene. And I don't know if you, if your DEMCA data perhaps included information that maybe we were seeing higher refusals because we were seeing longer times on scene, that maybe treating some of these cases that there would have been more treatment done en route with the goal of transport. So I was curious about time, and then also bringing up this table 1 again. So these unadjusted comparisons, I know a lot of collinearity issues, I guess, exist, but really great to look at this. And I was thinking about that no vehicle available, which probably related to a lot of other things, but I thought that was super interesting because I was just thinking intuitively, I mean, a lot of this sort of unfortunately is what we would expect, unfortunately, but that one I was thinking, if they're calling EMS, you would think they would,
it's the opposite direction of what
they don't have, exactly. Yeah. I was curious your thoughts on that, and then also if you had time or maybe looked at that, but you didn't include it in this study in terms of scene times.
Yeah, to the first question, we didn't have scene times that we were able to include in this study, although I think that's definitely a good question. In addition to time on scene, another potential variable in there is time of day too. It's quite possible that people are, and actually I think now in retrospect, knowing, no pun intended, but knowing what what we found, especially when it came to the gender divide in our results, it would have been really interesting to see if there was, and sort of what our own hypothesis was of what was causing that gender divide. It would be really interested to see if there was a difference like during banker's hours or during nighttime, and seeing, it's one of the things that we thought, just speculating, might be underlying some of this is lack of childcare and that kind of thing. And so if you saw some corroborating thing between time of day, maybe that would help. So yeah, those are a couple things that we would love to have looked at as well, and I think would be good in the future. As far as the individual SVI variables and stuff like the no vehicle available, that really stuck out to me too. And that's as we've been talking about, these are all unadjusted analyses. It's retrospective data, so you always have to be cautious in what you're interpreting. But I think when you see something where the measure of effect really goes in the opposite direction of the null hypothesis, that gives you a modicum of a higher strength of suspicion that there's really something going on here. And that was one great example. I'm glad you brought that up. That really stuck out to me too, that, we would assume that people who had more access to vehicles would be more likely to refuse because they could just drive themselves. Because maybe they're those people who, say, no, I don't want EMS to take me. I'm just going to go in by private vehicle. But that didn't really seem to be the case there.
Absolutely. After I've checked that I haven't coded the variable backwards, then I always have that. So obviously, one of the key findings of this paper is that the voluntary refusal of transport increased, but I like that you used the pre-period as well, because we saw that there were some differences even before the pandemic in terms of women were less likely to be transported, and then that was exacerbated during the pandemic. The effect size got bigger. Were there any other variables that caught your eye that were true before the pandemic and then were more exacerbated during?
Yeah, I think the gender difference was definitely a big one for us. Exactly what you said, that it was interesting that in the pre-period it was a predictor of refusal, or was associated with refusal, but it became significantly stronger of a association with refusal in the pandemic. And that suggests that this isn't necessarily, or that one of the forces at work may not necessarily be something specific to the pandemic, but something rather that the pandemic is exacerbating, some underlying issue that's already there that the pandemic just made much worse. And our main speculation on that was that knowing how many people were out of work, and then the disproportionate effect on women leaving the workforce, and then on women, having much higher share of childcare time overall in the U.S. We can only speculate that, maybe that's one thing. We know that childcare has been a huge issue once schools were closed, and then once everyone is there at home and people are out of a job. Is that something that's causing people to refuse because they have to choose between taking care of their health or taking care of their kids, which is awful to think about. But that's one of the things that we were very strongly wondering when we saw some of this data. I think one of the things that was interesting to us was that age wasn't as big of a predictor as we thought it was going to be. And it's possible that we just didn't have the sample size to accomplish that, although we had 80,000 patients. And so it's I don't know. But I thought that was actually kind of interesting, because one of the things that we wondered about was, is this going to be more older people who are refusing or younger people? But it turned out that it was roughly the same year to year. And then I think certainly, again, patients who are the most socially vulnerable overall by the composite SVI, refusing care more. Unfortunately, that's kind of what we expected, but it was also something that was pretty stark to notice, that it changed as much as it did. It was, I think, most interesting looking at the end of the time period. So as COVID cases spiked during this time period, you have this massive increase in deaths and in refusals going along with COVID cases spiking. But then one of the reasons why we chose this time period is because it captured a maxima and a minima of both COVID cases locally in Detroit, and also at that time, sort of the most heavy duty public health restrictions, versus some of the biggest lifting of those restrictions, up through that period of time. And what we found is, when restrictions were lifted and cases were down to like single digits in a day, there was still like roughly 1 in 10 extra, or 1 in 10 runs extra compared to 2019 resulted in refusal. And that was kind of interesting to see that, okay, this isn't maybe just a function of COVID-19 prevalence or of restrictions, because that was something else we thought about. There was some previous data that was out there that showed that EMS runs had gone down, but that visits for injuries had also gone down. So one of the things we were thinking of in our head was, okay, well, people are remote working, maybe, there's less car accidents, and we knew that there were less car accidents at the time. Maybe that's what's going on. So it was kind of interesting.
Also, I think that the concept that the pandemic and the interactions with the healthcare system, including EMS, have permanently changed in ways we still don't understand.
Yeah. I mean, just the idea that the social determinants of health and healthcare disparities clearly aren't new. They're something that have, pervaded our healthcare system for forever. And I think one of the things that really was reinforced for me was just how much a catastrophe like this, the pandemic, can really take things that are already underlying, that are just there and are just part of our healthcare system for years and years and years, and just send them into overdrive, and really highlight what really we should, we should be aware of and working on all the time, but they only become all the more apparent and all the more impactful on people's lives when a crisis like this happens.
Right, back to the concept that your census traction determine your outcome.
Yeah,
right. Absolutely. And it's key for EMS, who sits at the intersection of public health, to be aware of the influence of social determinants of health. So I really like how this paper highlights that. And they say that time flies when you're having fun. So I'm going to let Jeff Rollman ask our last question before I turn it over to you authors for any last words before we close. Jeff?
Thank you. Thank you. Thanks for plugging public health. I was curious, kind of your closing comments in terms of policy implications and what's next. We know obviously there's a lot of work to be done, and EMS is very much changing, but what do you think? Do you see anything maybe in terms of community paramedicine, mobile integrated health, dispatch centers having nurses, or doing more than sending an ambulance to every single 911 call? Kind of your thoughts on what this terrific research, maybe some policy implications coming out of this.
Yeah, I'll answer really quickly because I feel like as I'm ought to do, I talk way too much, and I'll let Rob say what he thinks too. I think for me, the two biggest immediate thoughts that I have are a need to understand, again, prospectively, what is the driving factor between people who are refusing care, and what kind of care are they refusing? So not all emergencies are emergencies, right? Sometimes 911 gets called for things that aren't even medical emergencies. And I think having, you mentioned community paramedicine, or just having someone else out there going to the community and sort of understanding at a case-by-case level what is going on, to map that out closer, so that then you can affect policy changes to inform that, and make sure that we aren't having people choose between, their health and their family or whatever else it is. I think that's a big.
That's huge.
So the things that we've done, like some of those things are great interventions that we've not had the resources to do, but we've expanded telemedicine. Now we have every single unit has telemedicine capability. All of our base hospitals have the ability to interact with the patient, so that EMS isn't out there on their own having to interact with that patient. The other thing is that We have enhanced some referrals directly from EMS to some community resources. We have some limited mobile integrated health going on in our community, but that's something we hope to use data like this to support the expansion of and get some more funding for that. But our easiest was to give that extra safety net of EMS-based telemedicine to every single one of our units.
And that is key. That's absolutely important. And we have rounded out the hour, but I want to thank you both again for your dedication to EMS research, one, and getting a paper published. We say time and time again is no easy feat. So thank you for the dedication it took to get that out there. And I would like to offer you all any last words or any last things that you'd like the audience to remember going home. And so, Dr. Harrison, I'll start with you.
Well, I first thank you again, Remley, for having us on. And I think as far as last words, I keep in mind, like, if nothing else, like that you take away from this, just keep in mind how much the quote unquote non-medical factors of medical care affect people's lives, and like how important and sometimes far more important than what we would consider the medical side of things are to people's overall health.
And what I would like to tell people is to use your data, really use it, really find ways to link it to bigger picture data, and don't be afraid to ask any questions about your data. And if your data doesn't answer them, try to find ways to get some help. This is the first project, or actually I think the second project I worked on with Nick, but we were kind of operating in a little bit separate worlds, and we connected for this, and it was great for both of us. So find people that can help you make the most of the information you're collecting every day.
Absolutely. And since I get to have the last word before I boot us out of here, I want to highlight something that actually Nick said early on in this podcast, and that is how important it is to have the EMS data to complete the larger picture. And so, if we didn't look at things like those spikes in out-of-hospital cardiac arrest, we're missing a huge part of this pandemic. And that applies not only to COVID-19, but to a number of other things that are going on in the world, whether it be opioids or you name it. And so EMS data is key, and that documentation really does matter. So sadly, we have reached the end of this podcast, but as a reminder, I want to let you all know we have the education version of this Journal Club podcast coming up Friday, November 26th, and we will be back here for our last clinical podcast of the year on Monday, December 13th. Thank you all again for listening, and a huge thank you again to our authors. See you next time.
Thank you.
Thank you, everyone.